Hello friends, today we'll talk about a very challenging case. This case is a 50-year-old male patient with complaints of severe both lower limb and upper limb tingling, numbness and weakness in his hands and legs. Patient has been having these symptoms for a couple of months now and then he visited me. The diagnosis that was made was a cervical myelopathy due to OPLL, which is a opacified posterior longitudinal ligament. So now I'll explain you what are the findings as seen on the CT and MRI. If you can look here, this is the MRI scan of this patient. So you can see this is the brain, this is the spinal cord, these are the bones, and then these are the discs. If you can see this blackish material that is compressing on the spinal cord. So this is the opacified ligamentum flavum, is basically a ligament. If you can see here, this is a ligament, but in some cases it becomes calcified and the calcium deposits accumulate and it sequentially goes on compressing the spinal cord. If you can see here in this cut, the cord is quite significantly compressed, especially on the right side. Now if you turn your attention to the axial cuts, so if you see, this is the spinal cord at the top level. There is a significant good space around the cord. You can see the whitish material over here, so that is the CSF. But as you go down, you can see this blackish material compressing on the spinal cord over here. In fact, the spinal cord has no space at all. So this is a very severe cord compression. Now we did an additional CT scan for this patient. In CT scan, usually the bones are seen. If you can see this ligament, the flavum that is opacified, or the mass that was pressing on the spinal cord, has a lot of calcium deposits. You can see here it is significantly occluding the spinal canal. So surgery in such patients is quite challenging, because in order to have symptomatic relief, the cord must be completely decompressed. Until the compression on the spinal cord is taken out, the patient will never improve. In fact, such patients starts deteriorating with time. In such patients, we have to take a surgical options. Now surgical options are of two types. Either you go from the front, which is the anterior surgery, or go from the back, which is the posterior surgery. Operating from the front in such a severe cord compression is quite challenging, because when you are operating from the front, that is, if you go from here, while removing the mass that is over here, you can inadvertently put pressure on the spinal cord, and thereby symptoms can worsen. In fact, even patients can land up in paralysis. So therefore, after informed decision making, we took a call of doing a posterior surgery. That is, what we did was we removed this piece of bone, that is the ceiling of the spinal cord. That way we never touched the bony material that was in front, and the cord automatically drifted back and was decompressed indirectly. Thereby we avoided any inadvertent complications in the form of paralysis. This case had to be done under strict neuromonitoring control, where a team of neurologists was continuously monitoring the signals arising from the spinal cord. Such special surgeries require a team of efforts from all other staff, as well as neurologists, anesthetists and the nurses. The EMG impulses and the nerve conduction values that were continuously fed into me helped me decide what kind of pressure I can put on the spinal cord while decompressing the spinal cord, thereby avoiding undue excessive pressure and further causing damage to the spine. The surgery as such was quite prolonged, mainly because of the positioning and setting up of the OT. But subsequently, post-surgery, patient has recovered now, and immediately the next day patient was about to walk. He could climb stairs, and patient was discharged home after 3 days.